So we're going to take two horizontal planes, two vertical planes, and break them down into into 9 different regions. The upper region is broken up into the right hypochondriac, and it's chondriac referring to what structure? The cartilage of the ribs, right? So this is going to be your right lower rib region. Then you have your epigastric, referring to the area around the stomach, and then your left hypochondriac. In the middle section here, we have the right lateral or right lumbar region, the umbilical, yes, the umbilical, and then the left lumbar region. And then the lower row, you have the right inguinal, the pubic, and the left inguinal. Also be familiar what structures are located in these different regions. Topographical landmarks. Okay, mid and upper abdomen landmarks includes the xiphoid tip, located at the level of T9, T10. The inferior costal margin is located at the level of L2, L3. And then the iliac crest is located at the level of L4, L5. Do we have any questions about these landmarks? I mean, we've been practicing these landmarks over and over again in different studies. We've palpated for the xiphoid tip and the iliac crest. The inferior costal margin we don't use a lot, but again, you need to be familiar with the level it is located, which is L2, L3. Okay. So other ones is your as-is, your trader trochanter, which is at the same level of your symphysis pubis, and then the ischial tuberosity. Ischial tuberosity is there, but again, one of those things that we don't palpate as much because of its location. All right. All right. Why do we do an abdomen? Whoa. Why do we do an abdomen study? Number one is to evaluate the contents of the abdomen. Number two is to localize tube placements, tube and line placements. Put somewhere here tube and line placements. So tube and line placements. Number three is a scout film for contrast media. Now, I'm going to spend a little bit of time here on scout film. Basically, what a scout film is the preliminary film that we do before we do the actual study, if it involves contrast. We do a preliminary film. Let's just say, for example, we're going to be doing a small bowel series. Patient's going to drink the contrast and fill up the stomach, fill up the small bowel, small intestines with the contrast, okay? So before we have them do that, we take a scout or a preliminary image and we study that, because what will happen is once you take in the contrast, things can be missed. Because the contrast can block things, because it's solid, it's radiopaque. So if there was something there before, we couldn't see it because now they drank or ingested the contrast agent. So we want to see a before, and then we want to see the during. Does that make sense? So we take a scout film. The scout film is also done to make sure that the patient followed the explicit guidelines for preparation for the exam. In other words, we want to make sure that their bowels are empty. So that's another reason why we do that. And if they're not empty, the doctor will say, no, we can't do the study. Because when they drink the contrast and there are still contents in the small bowel and the large intestine, it may show up as some sort of tumor because of fecal material. Does that make sense? All right. So scalp films are done before a contrast study is done. Rules out any type of anomalies and make sure that the patient is prepped. Number 4 is to rule out free air. Remember the peritoneum, you have visceral and you have a parietal lining, and if that lining breaks, you can have fluid that leaks into the cavity, or you can have air that leaks into that cavity. So we will do it to rule out free air, and also to rule out any type of fluid buildup, just like we do in the lungs. To visualize stones and also to localize foreign body are some reasons why we do an abdominal study. Okay. Just going to roll through this as quickly as I can. Stones. Now, before I move forward, can you guys see that there's a density that comes from here and it kind of flares out like so? You see this right here? It's this real subtle density. You will see this in all your abdominal radiographs. This structure that we are visualizing here and here, those are your psoas muscles. P is silent. I'm sorry, I was thinking of a joke that I heard the other day. I know, I'm kind of thinking of how it goes so I don't mess it up. How do you know if a pterodactyl is using the restroom?
How?
You can't because the P is silent. You know what they call that? They call that an uncle joke.
King of the one-liners.
Yeah, because only uncles tell jokes like that. Corny jokes, it's an uncle joke. All right, so the psoas muscle, the P is silent. So the psoas muscle is related to the bending. So it allows you to bend. It allows you to move from side to side. It's most commonly known as, it's attached to your hip flexors, so it allows you to bring your legs up, like so. Okay, that's the psoas muscle. You see them on majority of the abdominal x-rays. So you see it extending right around here about the level of L2, L3, and it extends all the way down to your hip. See that extra density? All right, it's kind of hard, it's kind of a bad x-ray to also look at because the stomach is full of different types of contents. Let me see if I can get you a better one here. Residual contrast, okay? So here's one with residual contrast. This individual here had ingested some contrast agents. It may be causing some kind of abdominal discomfort, so they did a follow-up to examine whether or not the contrast had been fully evacuated. Can we tell the age of the patient?
No.
Okay, again, it's a young kid, right?
Mm-hmm.
Because of the lack of development here of the bones.
Mm-hmm.
Still wide open. Foreign body. Okay. Anybody want to take a stab at this?
Is it like a little knife?
Another uncle joke. Okay. So that's a knife in the abdomen. Can you guys see the outline of the psoas muscles again?
Mm-hmm.
Okay, you can't really see it here, but you can see it coming down this way.
Yeah.
What is this right here? This is your liver shadow. See, this is what it see as the ascending goes up and then it stops right about there. So your flexure will be around here, but right on top of that will be your liver. So wherever the large colon starts to take a turn, that is the inferior border of the liver. Make sense?
Mm-hmm.
Okay. And all this black areas here in the bowel, what's all that?
Gas.
That's gas. Okay, so air is dark. So this is air in the bowel. Foreign body.
Coin.
Okay. Yeah, so it's some kind of coin, right? Here we have diaper pins. This is a coin. Yeah. Yeah.
Mm.
Yeah, diaper pins right here.
That's an old X-ray.
Yes, yeah. It's retro. Again, a child, right? Because we can tell by the bone development.
Mm-hmm.
What area is this?
Stomach.
Right? Everybody agree? Stomach. Come down this way. And then what's all this in the middle? With air, that's your small bowel.
Mm-hmm.
What's this area right here?
Liver.
Liver shadow. Okay, good.
Is that gonna pass?
Eventually.
The shadow above the stomach, that's the spleen?
The shadow here?
Yeah.
This is your lung.
Oh.
These are your lungs, air in the stomach, and then here's the heart shadow right here. Heart shadow, right lung, left lung, diaphragm, base of the lung.
So you can't really see the spleen in a regular radiograph?
Yeah, it's hard to see because it's in the back.
Oh,
It's
okay.
in the back of the stomach. Okay. You will get called frequently to do chest x-rays, to do abdominal x-rays for line placement. Did we mention before that this is important in the survival of the patient? Because once they put the tube down there, we want to assure that it's in the right place, especially if it's a feeding tube. Remember here, you have your trachea and your esophagus. If the tube goes down in the wrong place, let's just say somewhere in one of the bronchi, and you start using it to put food through it or nutrients, you can drown the patient. So they'll use these different types of x-rays to make sure that the tubes are in the correct place. We'll do it for thoracotomy, chest tube placements, we'll do it for EG tube placements, we'll do it for feeding tube, PICC lines, central line placements. You will get constant calls for these type of x-rays to make sure the tip of the catheter or the line or the tube is in the right place.
Do you guys do a lateral in addition to this right here to look at it, or just?
No, not necessarily.
Okay.
No. It's always going to be, especially if you're doing it portably like this, it's always done in an AP. AP chest, AP abdomen. All right, so here we have an ET tube. Okay, here's your ET tube right here. The tip of it's right about there. Can you guys use your X-ray eyes now? Here is the trachea, and can you see it splitting into the right and into the left?
Mm-hmm.
Okay. ET tube placement is perfect because the ET tube should be located right at the bifurcation between the right and the left. So here's the tip, and it's right above where it bifurcates. If it goes too far, if this chest tube goes down too far, did we talk about?
Right.
Yeah, we said it's going to go to the right, if anything else, right? Because the right is more vertical than the left. And if that happens, then it's the right that's going to be aerated, okay, getting the oxygen where the left one doesn't, and the left one could collapse. So right above the carina is where both the left and the right will be properly aerated. And then here we have a chest tube. You guys remember the chest tube? Okay, the chest tube is placed whenever there is fluid or air in the pleural cavity, so we try to get it back into normal equalization of air pressure. Feeding tube. So feeding tube comes like this.
You can use fluoroscopy instead of chest X-ray.
You can use fluoroscopy, but you can't bring. I mean, you can bring your fluoroscopy unit to the like an ICU, but you're going to be spending 15-20 minutes just to set that up. And then fluoroscopy uses more X-rays than just your standard, just one shot. Okay, so you have your feeding tube here. Actually, they have two feeding tubes. You have this one goes like this. No, this one looks like this. This loops. Okay, and then this one goes like this. So here's the tip of one. Here's the tip of the other. Okay, any questions? Patient preparation for an abdominal x-ray. What do we need to do?
Remove everything from the waist
Remove
up.
everything from waist up, waist down?
Waist up.
Everything, right? Everything, leave your underwear on. How about the if a bra? Can we leave a bra on?
No.
No.
Okay. Necklaces?
Just to be safe.
Just have them remove everything, yeah, to be safe. Okay. All clothing must be removed, opaque objects especially. Place them in a hospital gown. If they're going to be laying on the table, please be mindful. They'll be laying on the table for a while, depending on the type of procedures that you are doing. Give them a pillow. Put some cushion underneath their leg to relieve some of the pressure off their back. Why don't we just use a pad? You guys ever wonder why we don't use a pad, or why doesn't everybody use a pad? Some places do and some places don't. Because the pad, the lining of the pad may show up on the x-ray. That's right. Here's the other thing. Pads are usually like this. Remember a pad in the back? It's this thick. You think that's going to cause some OID? So it's going to affect also the quality of your image. That's why we rarely use pads, because it may show up on the x-ray and because of the increased OID. All right. Position considerations. When doing an abdomen, we normally do it on expiration. We generally do it lying down. Right? Lying down. What happens to the diaphragm?
Goes up.
Goes up. Why do we do it on expiration?
Pushes it up farther.
The diaphragm also stays up. It goes up. Okay, so we're getting more abdominal real estate than we would if we did it on inspiration and upright. But again, there are exceptions. Okay? Most abdominal x-rays, if it's not an adult, it's done on the large image receptor, generally 14 by 17 lengthwise. Okay? Shield when appropriate. If it doesn't interfere with the study, shield. If the study is necessary, it's a must-do. Use a shield, but it's going to show up on your x-ray, but it's a must-do. We have to do it. Otherwise, we delay. All right, what's your general KV? General KV. It's between 70 and 80 KV. Generally 7 to 80 kVp. What is our range, contrast range?
Long scale.
Long scale? We want long scale or we want short scale?
Long scale.
We want long scale, okay? We want long scale. Short exposure times. Why is that necessary? We're telling them, we're telling them to hold their breath on expiration, right?
The
Peristaltic movement.
Peristaltic activity, okay? So there's still that activity going on with the abdomen, so short exposure times will minimize the movement. All right. What's this? See where my arrow is? What's that? It's coming down like this. It's a J shape. Okay, somebody said stomach. Good, that's your stomach. What are these? Psoas muscle. What is this?
Liver.
Liver shadow. What is this?
Your ascending colon.
Air and what?
Ascending
Air
colon.
and the ascending, okay? We can also see air coming down the descending, okay? And then this area here,
Bladder.
okay? That can be small bowel, it can be large bowel. That can be your rectal area. And then you can also see the shadow, this round shadow right here.
That's the bladder, right?
That's the bladder. You guys have good x-ray eyes, good. Okay, short scale, low contrast, short exposure times. Use a grid over 10 centimeters or for parts greater than 10 centimeters. If you are using your AEC, use 3 cells. Use 3 cells. I generally just use the center cell, but again, varies from facility to facility. You do as they tell you to do. Okay, breathing instructions done on expiration. All right. Generally no prep unless it's a fluoro study. So if you're just shooting an abdominal x-ray for survey, No contrast. There is no prep. Again, you want them to remove all their clothes, socks, with the exception of the socks.
Keep your shoes
If possible, keep the patient in an upright position for about 5 minutes. If possible, keep them in an upright position for 5 minutes. Remember the criteria of why we do some of these abdominal studies is we're evaluating for air and fluid levels. Okay, so try to keep them upright for about 5 minutes. 10 to 20 if possible. 10 to 20 if possible. Okay. We'll talk about the position considerations here in just a moment. Large humerus receptor, something underneath their legs to alleviate some of the pressure on their back. These are the routine studies that we do for an abdominal study. Okay. We'll start with two-way, and then I'll go up here. Two-way. A two-way is also known as an abdominal series. Two-way is known as an abdominal series, which consists of one supine. What's the other one?
Upright?
One upright. One laying down, one standing up. Okay? So that's your abdominal series. One supine, one upright. Everybody got that?
Mm-hmm.
Three-way, one supine, one upright, and an upright chest. An upright chest. Why are we doing an upright chest? What are we looking for in an upright chest?
Esophagus?
Let me go back over here if I can find an x-ray.
Bifurcation of the
Okay.
tube.
Here's an abdominal x-ray. When you do an abdominal x-ray, everything is, it's long scale, everything is gray. So if we're looking for air that has leaked out of the cavity, where does air go?
Up?
Air goes up. But it's hard to see this area because it's too dark. So what we will do then is we will take a chest x-ray to evaluate the area near the diaphragm. That is why a chest x-ray is included. With a chest x-ray, it's going to be lighter around the area of diaphragm to help us identify if there is any air in the peritoneal cavity. Is that your stomach?
Yes.
All right, guys, so all right, so two-way, supine and upright. This is known as the abdomen series. Three-way, which includes an upright chest x-ray, is known as an acute abdominal series. Acute abdominal series, or the acronym AAS. AAS for acute abdominal series. Pay close attention when you get a requisition to do an abdomen. Does it say abdominal series or does it say acute abdominal series? If it's acute, it includes a chest x-ray. Okie dokie? All right. If you're doing mobile, we're going to be using a grid, yes? Because we use grids for body parts greater than 10 centimeters, right? So when we're doing mobile radiography, that means we're taking the x-ray with the patient on the gurney or on the bed. You guys studied grids already, right? And peripheral grid cutoff, right? So the grid has to be level with the bed. If they're laying on it, you don't want it, you know, not flat, because any changes or angulation on that grid can cause grid cutoff. So that's one of the toughest things to do, is making sure that the imaging plate is level. Try to use a low grid ratio. Why do we want a low grid ratio versus a high grid ratio? I thought high grid ratios were good.
Greater margin of error.
Larger margin of error. You guys are good. And also positioning sponges if necessary to make sure that the patient isn't demonstrating any type of rotation. All right. Pediatric patients, make sure you have an immobilization device. Shielding, short exposure times applies to all patients, but especially with pediatrics, because they are going to be moving around a lot. They may also be crying. Short exposure times are good. Okay. Okay, alternate imaging procedures for the abdomen include CT, ultrasound, and MRI, nuclear medicine. You guys can go through these images yourself. I'm not going to spend too much time on that. Some procedures that we will do of the abdomen includes the SCG. I think in your slides it's just the acronyms. HSG, which stands for hysterosalpingography. Hysterosalpingography. This is a procedure done especially for women in the studies of the reproductive organ. So it does show whether both fallopian tubes are open and whether the shape of the urine cavity is normal. It's a highly sensitive type of procedure that only females can do. Okay. It is special procedures. The patient may be sedated. Okay, very painful type of procedure. It's also a very good procedure because although it's diagnostic, sometimes it may be interventional. So they're going in there, shooting contrast, evaluating the tubes, and they straighten out the kink. Okay? Not sure HSG. HSG. Next one here is barium. Barium enema, BE. It's an exam to evaluate the large intestines with the use of barium. Upper GI also. Patient drinks barium. Here we are evaluating the esophagus, the stomach, and the partial section. Part of the section of the duodenum and possibly the jejunum. IVP stands for intravenous pyelogram. It may also be referred to as an IVU. Remember a few slides back, IVU? IVU and IVP are used interchangeably. IVU is intravenous urethrogram, whereas IVP stands for intravenous pyelogram. Names are used interchangeably. Okay? Any questions here? Yes?
That's not a nurse slide.
No.
That's what I said.
Yeah, just the.
Yeah, I said it